Welcome once more to this YouTube channel. Kindly subscribe to this channel. The topic is pelvic viscera. This is part 2 of this lecture, pelvic viscera part 2. I'm going to start right away by talking about the male internal genital organs. Right here is an illustration of the male internal genital organs. Take a close look at the diagram there, and you will see the testis, the epididymis, the ductus deferens, what is also called the vas deferens, seminal glands, the ejaculatory ducts. They are all illustrated in the diagram there. That's the male internal genital organs in the pelvis. So the male internal genital organs include the testis, the epididymis, ductus or vas deferens, seminal glands, ejaculatory ducts, and prostate. The prostate is also illustrated in that diagram. We also have the bulbourethral glands. Looking at the external, the testis and epididymis are external in position. They are external, but you might be wondering why we call them male internal genital organs. Yes, the testis and epididymis are considered as internal genital organs on the basis of their developmental position, where they come from. They actually come from the internal part of the body. So in development, so we consider them as part of the male internal genital organs. You also have, for the females, you have the ovaries. They are homologous with the testis for the male. But I'm talking about the male internal genital organs here that you have in the pelvis, and I'm going to go on right away to talk about the ductus deferens, what we call the vas deferens. Take a close look at that diagram there. You're going to see the ductus deferens. There is a duct, it's a duct. The ductus deferens has relatively thick muscular walls and a minute lumen, and this gives it a cord-like firmness. The ductus deferens begins in the tail of the epididymis at the inferior pole of the testis. The ductus deferens ascends posterior to testis, medial to the epididymis. The ductus deferens, also called the vas deferens, is the primary component of the spermatic cord. It penetrates the anterior abdominal wall via the inguinal canal. The ductus deferens crosses over the external iliac vessels and enters the pelvis. The ductus deferens passes along the lateral wall of the pelvis. Here it lies external to the parietal peritoneum, and it finally ends by joining the ducts of the seminal gland to form the ejaculatory ducts. You must know that during the pelvic part of the course of the ductus deferens, it maintains direct contact with the peritoneum, so you have no other structure intervening between the ductus deferens and the peritoneum in the pelvis. The ductus deferens crosses superior to the ureter near the posterolateral angle of the bladder, and as it does so, it runs between the ureter and the peritoneum of the ureteric fold, and it now gets to the fundus of the bladder. Note that the relationship of the ductus deferens to the ureter in the male is similar, although it's not of much clinical significance, just like what you have in the female. In the female, you have the uterine artery. It's actually the uterine artery that runs, that is doing what the ductus deferens is doing in the male. The relationship of the uterine artery to the ureter in the female is just like that of the ductus deferens to the ureter in the male. Posterior to the bladder, the ductus deferens, you find that first it lies superior to the seminal gland, then it now descends medial to the ureter and the seminal gland. and as it descends, the ductus deferens enlarges to form the ampulla of the ductus deferens before it finally gets to its termination. What is the arterial supply of the ductus deferens? There is a tiny artery to the ductus deferens which usually arises from a superior or inferior vesical artery. Most times you find the artery to the ductus deferens coming from the superior vesical artery. Occasionally it comes from the inferior vesical artery. And this artery, the artery that supplies the ductus deferens, terminates by anastomosing with the testicular artery, and this anastomosis is seen posterior to the testis. What about the venous and lymphatic drainage of the ductus deferens? You have veins for most of the ductus deferens draining into the testicular vein. You also have the distal pampiniform plexus, which is the terminal portion. The veins, the network of veins that you have at the terminal portion is the distal pampiniform plexus, and it drains into the vesicular and prostatic venous plexuses. You either call it vesicular or prostatic venous plexus. Lymphatic vessels from the ductus deferens end in the external iliac lymph nodes. So the lymphatics that drain the ductus deferens drain into the external iliac lymph nodes. Now permit me to talk about male sterilization. A very common method of male sterilization is deferentectomy, popularly called the vasectomy. When you want to do male sterilization, a common method you can use is the deferentectomy or the vasectomy. So when you're doing this procedure, part of the ductus deferens is ligated. It's ligated, or you could excise completely through an incision in the superior part of the scrotum. You have, after this incision, either you are ligating, you ligate and then you could excise. Either you are ligating or you are ligating and excising. When you do that, the subsequent ejaculated fluid from the seminal glands, prostate and the bulbourethral glands will contain no sperms. The unexpelled sperms degenerate in the epididymis and the proximal part of the ductus deferens. If you wish to reverse deferentectomy, you could do a reversal of the deferentectomy, and it's usually successful in patients that are young, like those that are younger than 30 years of age, and the ones that are quite children in most cases. So when you want to reverse the procedure, the ends of the section ductus deferens are reattached, and you do that with under the guidance of operating microscope. Next, the seminal glands. I'm still talking about the male internal genital organs that you find in the pelvis. Seminal glands. Right here is an illustration of the seminal gland, also called the seminal vesicle. Taking a close look, you will see that it's an elongated structure. It's about 5 cm long, but at times it could be shorter, and it lies between the fundus of the bladder and the rectum. The seminal glands are obliquely placed and they lie superior to the prostate. They do not store sperms. So the seminal glands do not store sperms, unlike contrary to what you're tempted to believe because of the name. What they do is to secrete a thick alkaline fluid that contains fructose, and this is a good energy source for the sperms. They also release a conjugating agent that mixes with the sperms as they pass into the ejaculatory ducts and urethra. The superior ends of the seminal glands are covered with the peritoneum and lie posterior to the ureters. And at this point, the peritoneum of the rectovesical pouch separates these superior ends of the seminal glands from the rectum. The inferior ends of the seminal glands are closely related to the rectum and are separated from it by the rectovesical septum. The duct of the seminal gland joins the ductus deferens to form the ejaculatory duct. Now, the arterial supply of the seminal glands, how is it like? You have arteries to the seminal glands coming from the inferior vesical and middle rectal arteries. What about the veins and lymphatics? The veins accompany the arteries and they have similar names. The internal iliac lymph nodes receive lymph from the seminal glands. The external iliac lymph nodes actually receive lymph from the superior part of the seminal gland, and internal iliac lymph nodes receive lymph from the inferior part of the seminal glands. To worry about abscesses in the seminal glands. Abscesses could occur in the seminal glands. That is actually localized collection of pus in the seminal gland, and this might rupture. When it ruptures, the pus enters the peritoneal cavity. The seminal gland can be palpated during a rectal examination, especially if enlarged or full. They are palpated most easily when the bladder is moderately full. The seminal glands can be massaged to release their secretions for microscopic examination to detect gonococci, for example, in a case of gonorrhea. Remember, gonococci are the organisms that cause gonorrhea. Now, let me go on to talk about the ejaculatory ducts. The ejaculatory ducts. Right here is an illustration of the ejaculatory ducts. If you take a very close look, you will see that the ejaculatory ducts, they are shown, they're actually with the other internal genital organs. You see the ejaculatory duct not in isolation, of course. You also have the vas deferens and then the testis. It's also there. So the ejaculatory ducts are seen in the illustration here as slender tubes that arise by the union of the ducts of the seminal glands with the ductus deferens. So you can see both the ductus deferens and the ducts of the seminal glands coming together to form the ejaculatory ducts. The ejaculatory ducts are about 2.5 cm long. They arise near the neck of the bladder and run close together as they pass anterior-inferiorly through the posterior part of the prostate along the sides of the prostatic utricle. The ejaculatory ducts converge to open on the seminal corniculus, and they do so via tiny slit-like apertures. And these apertures, you find them on or within the openings of the prostatic utricle. The ejaculatory ducts traverse the glandular prostate. Even though they traverse the glandular prostate, the prostatic secretions join the seminal fluid in the prostatic urethra after the ejaculatory ducts have terminated. The arterial supply of the ejaculatory ducts is from arteries to the ductus deferens, and these arteries are branches of the superior vesical artery most times. Occasionally, the arteries will come from the inferior vesical artery. The veins that drain the ejaculatory ducts join the prostatic and vesical venous plexuses. The lymphatic vessels drain into the external iliac lymph nodes. Now it's time to talk about the prostate. Right here you see the prostate alongside the bladder, the seminal vesicle. They are all shown, and even the testis, they are shown in this diagram. But the emphasis here is the prostate. Take a close look at the prostate. It has a form of close to lemon color there, the prostate. This is some other illustration actually showing the various zones of the prostate. You can see the transition zone, you can see the central zone, the peripheral zone. The prostatic sphincter is also illustrated there. The prostate is about 3 cm long, 4 cm wide, and 2 cm in the anterior-posterior depth. The prostate is the largest accessory gland of the male reproductive system. The glandular part of the prostate makes up approximately 2/3 of the prostate. So the glandular part is actually a large portion of the prostate. The other third of the prostate is fibromuscular. You have a firm. The prostate is actually firm. It's about the size of walnuts, and the prostate surrounds the prostatic urethra. The prostate has a fibrous capsule which is dense and neurovascular. You actually have prostatic plexuses of veins. You find them incorporated into the fibrous capsule. You also have nerves incorporated into the fibrous capsule. That is why I said it's neurovascular. The fibrous capsule is surrounded by the visceral layer of the pelvic fascia, and this forms a fibrous prostatic sheath that is thin anteriorly and continues anterolaterally with the puboprostatic ligaments. It's dense. This surrounding prostatic sheath is dense posteriorly. At this posterior portion, it blends with the rectovesical septum. The prostate has a base. The base is closely related to the neck of the bladder. The prostate also has an apex. The apex is in contact with the fascia on the superior aspect of the urethral sphincter and the deep perineal muscles. The prostate has a muscular anterior surface which features mostly transversely oriented muscle fibers, and they form a vertically trough-like hemisphincter, what we call the rhamnosphincter. This sphincter is part of the urethral sphincter, separated from the pubic symphysis by the retroperitoneal fat, and the retroperitoneal fat is in the retropubic space. So I've said the prostate has a base, it has an apex, and it has a muscular anterior surface. That is not all. The prostate also has a posterior surface that is related to the ampulla of the rectum. Furthermore, the prostate also has an inferior-lateral surface. There are actually inferior-lateral surfaces you have on the right and on the left. These inferior-lateral surfaces are related to the levator-ani muscle. Although not quite distinct anatomically, but the prostate has lobes. It has lobes. There is actually the isthmus of the prostate, which is the isthmus is like commissure of the prostate, and there you have the anterior lobe lying anterior to the urethra. It is fibromuscular because there are muscle fibers that represent a superior continuation of the urethral sphincter muscle, and you also have glandular tissue as well. So the lobes of the prostate, there is an anterior lobe, then there is a posterior lobe as well. The posterior lobe Some persons call it the inferior posterior lobe. This posterior lobe lies posterior to the urethra and inferior to the ejaculatory duct. The posterior lobe of the prostate, also called the inferior posterior lobe, is readily palpable by digital rectal examination. Still talking about the lobes of the prostate, I've mentioned the anterior lobe, the posterior lobe or inferior posterior lobe. Then of course the right and left lateral, what we also call the lateral lobes. You find them on either side of the urethra and they form the major part of the prostate. You also have a medial lobe, middle lobe, some call it the medial lobe of the prostate. The middle lobe or medial lobe lies between the urethra and the ejaculatory ducts and is closely related to the neck of the bladder. When this middle or medial lobe enlarges, it could be responsible for the formation of an uvula that will project into the internal urethral orifice. So we talk about, I've mentioned the lobes of the prostate: anterior lobe, posterior lobe or inferior posterior lobe, right and left lobe or the lateral lobes, the middle lobe or medial lobe. Some authors, especially the urologists and sonographers, divide the prostate into peripheral and the central zones. The central zone is also called the internal zone. The central zone is comparable to the middle lobe I mentioned a while ago. Within each lobe, you have 4 lobules, which are defined by the arrangement of the ducts and connective tissue. The prostatic ducts are about 20 to 30 in number. They open chiefly into the grooves. That's these grooves. You have these grooves are actually, the structures are actually called the prostatic sinuses, and the prostatic sinuses lie on either side of the seminal corniculus, precisely on the posterior wall of the prostatic urethra. You have prostatic fluid, which is a thin milky fluid, and this prostatic fluid actually gives about 20% of the volume of semen. Semen is actually a mixture of secretions produced by the testis, seminal glands, prostate and bulbourethral glands. So the semen plays a role in activating the sperms. The arterial supply of the prostate is courtesy of the prostatic arteries, which are branches of the internal iliac artery. You also have the inferior vesical arteries, also giving arteries that innervate that nourish the prostate. But the internal, you also have internal pudendal and middle rectal arteries, also giving some branches that nourish the prostate. The veins that drain the prostate join to form a plexus around the sides and base of the prostate. They form a network, the prostatic venous net plexus, and you find this between the fibrous capsule of the prostate and the prostatic sheath. This prostatic venous plexus drains into the internal iliac veins. The prostatic venous plexus continues superiorly with the vesical venous plexus and communicates posteriorly with the internal vertebral venous plexus. The lymphatic drainage of the prostate involves lymphatic vessels that terminate in the internal iliac lymph nodes, but some of the lymphatics go drain to the sacral lymph nodes. We really need to get worried about hypertrophy of the prostate. The prostate is of great medical interest because enlargement, or what we call benign hypertrophy of the prostate, is common after middle age. Benign hypertrophy of the prostate affects virtually every male who lives long enough. When the prostate enlarges, it projects into the urinary bladder and impedes urination by distorting the prostatic urethra. That is why we really get worried. The middle lobe usually enlarges the most and obstructs the internal urethral sphincter or orifice. So the more the person strains to urinate, the more the valve-like prostatic mass occludes the urethra. So in benign prostatic hypertrophy or benign hypertrophy of the prostate, there is urethral obstruction, and it's a common cause of urethral obstruction in the male. And when it occurs like that, it leads to nocturia. So at night the patient has the need to urinate. You also have dysuria. The patient has difficulty and pain during urination. There is also urgency. There is a sudden desire to urinate to void the bladder. Benign hypertrophy of the prostate also increases the risk of bladder infections, what we call cystitis. It also causes kidney damage. So the prostate can be, in such, when it's diseased like that, it could be examined for enlargement and tumors. So you could have tumors as focal masses or asymmetry, and you could examine the prostate by digital rectal examination. The palpability of the prostate depends on the fullness of the bladder. So when the bladder is full, it gives resistance, holding the prostate in place and makes it more palpable, readily palpable. When there is a cancer, that's a malignant tumor of the prostate feels hard when you do rectal examination, and it appears irregular. In advanced cases of cancer of the prostate, the cancer cells metastasize both via the lymphatics, and as they do so, they go to both initially to the internal iliac and sacral lymph nodes, and later they go to distant lymph nodes. So they spread initially via lymphatics. Later the cancer cells spread via venous roots, and they do so by way of internal vertebral venous plexus. So they spread to the vertebrae and to the brain. So with time, the person might go into coma and might eventually die. Because of the close relationships of the prostate to the prostatic urethra, obstructions can be relieved endoscopically. That's with the use of endoscopic instruments. The instrument is inserted transurethral through the external urethral orifice, and it goes through the spongy urethra. It now gets to the prostatic urethra. All or part of the prostate, or just the part that is hypertrophied, is removed. That's what we call transurethral resection of the prostate, TURP, TURP. So if it's a very serious case, the entire prostate might need to be removed along with the seminal glands. Ejaculatory glands may be removed as well, and even the terminal parts of the ductus deferens. In that case, you are doing a radical prostatectomy. So transurethral resection of the prostate, and you could also have improved open operative techniques. Either you're doing the transurethral resection of the prostate, or you are doing some other open surgery. It can help you to preserve the nerves and blood vessels associated with the capsule of the prostate, because these nerves and blood vessels also pass to and from the penis, so that you can help the patient to retain sexual function after surgery, and also to restore normal urinary control. So when you are doing a prostatectomy, either via transurethral resection of the prostate or via the radical prostatectomy, you need to preserve the nerves and blood vessels associated with the capsule of the prostate, because these nerves and blood vessels also take care of the penis. so that sexual function is retained, and also you can restore normal urinary control at the end of the surgery. Next, permit me to talk about bulbourethral glands. I'm still talking about the male internal genital organs that you have in the pelvis. Bulbourethral glands. Right here, take a very close look. You will see the bulbourethral gland and ducts. There also you have the urethra and then the penis. The bulbourethral glands are pear size. They are shaped like the size of a pear. They are two, and they are also called the copper glands. They actually lie posterolateral to the intermediate part of the urethra, as you can see in that diagram, and they are largely embedded within the external urethra sphincter. The ducts of the bulbourethral glands pass through the perineal membrane with the intermediate urethra and open through minute apertures into the proximal part of the spongy urethra. If you take a good look at that diagram, you appreciate the bulbourethral gland, the ducts. Like I said, they go into the opening via minute apertures into the proximal part of the spongy urethra in the bulb of the penis. That is illustrated there. From the bulbourethral glands, you have mucus-like secretions that enter the urethra during sexual arousal. I need to talk about the innervation of the internal genital organs that you find in the male pelvis. So the ductus deferens or the vas deferens, the seminal glands, ejaculatory ducts, and the prostate are richly innervated by sympathetic nerve fibers. You have presynaptic sympathetic fibers originating from cell bodies in the intermediolateral cell column of T12 to L2 or L3 spinal cord segments. These presynaptic sympathetic fibers traverse the paravertebral ganglia of the sympathetic trunks, and they now become components of the lumbar, that's what we call the abdominopelvic splanchnic nerves, and the hypogastric and pelvic plexuses. You also have presynaptic parasympathetic fibers from S2 and S3 spinal cord segments, which traverse pelvic splanchnic nerves, which also join the inferior hypogastric and the pelvic plexuses. Synapses occur. So you have synapses with the postsynaptic sympathetic and parasympathetic neurons. And these synapses occur within the plexuses and go to the pelvic viscera to innervate the pelvic viscera. As part of an orgasm, the sympathetic system is very important because it stimulates rapid peristaltic-like contractions of the ductus deferens, and the combined contraction and secretion from the seminal and prostate glands provides semen, and the expulsive force to discharge the sperms during ejaculation is also provided, courtesy of this sympathetic system stimulation. So the sympathetic nervous system is very important in the production of semen and also in ejaculation. The function of the parasympathetic nervous system that also innervates internal genital organs is not quite clear. The sympathetic appears to be more important. However, the parasympathetic fibers traversing the prostatic nerve plexus forms the cavernous nerves, and these cavernous nerves pass to the erectile bodies of the penis, and they are responsible for producing penile erection. So the parasympathetic nervous system is very important in erection. So we cannot just write off the parasympathetic nervous system as far as innervation of the male internal genital organs is concerned. So you have a table actually showing the arteries, some of the arteries I mentioned earlier on that nourish the internal genital organs in the male, the pelvic internal genital organs that you find in the male. So all the arteries I mentioned that nourish these organs are all illustrated in this table. You also have a table showing all the lymphatics that drain the internal genital organs in the male, the lymph nodes that they drain into, just as I mentioned in the course of my discussion. Thank you so much for listening. I really appreciate your time. Don't forget to subscribe to this channel. Do check out part 3 of the lecture on pelvic viscera. Goodbye for now.